Hello. Sorry for this initial hiccups. We'll be talking today about understanding the operative procedures and assessment for univentricular heart repair from palliation to Fontan. See, one thing we need to remember or realize that Fontan operation is an effective palliation for complex heart defects. And especially if we try to counsel the parents also, we need to tell them that it's not a corrective procedure, but it's an effective palliation. And we are trying to review how the long-term results and the quality of life of the procedure over a period of time. And another very, very important thing is the success of Fontan operation depends upon proper patient selection. So the whole onus lies upon the cardiologist for selection of the patients. And remember, Fontan is all of physics. It's all your flows, diameter, resistance. So unless you decide everything very correctly, there is a high chance that you may not have a proper patience and your success will be a problem. And this is all a venous system. So even a 1 millimeter and 2 millimeter of pressure difference and a size difference definitely matters for success of the procedure. So let's see how we try to assess the patients for preoperative Fontan. What is the surgical definition of a single ventricle repair when we are not able to establish two independent functioning ventricles to support in series? So that may be because of either you have inadequate ventricular size and volume, ventricular size or inadequate ventricular volumes, or you have lack of independent inflows. Third thing is you are not able to establish adequate left ventricular outflow. Now take one example. When you have inadequate ventricular size and volume, we talk of a patient something like a tricuspid atresia. You have one big ventricle, other small ventricle, so you have inadequate ventricular size, you have an inadequate ventricular inflows. The second thing is you have unbalanced AV septal defect. You have one ventricle which is big, one ventricle which is small. The second thing is lack of independent inflow. You take the example of tricuspid atresia, mitral atresia. You have only one inflow. You don't have two independent inflows. The third thing is unable to establish adequate LV outflow. You have a classical example of hypoplastic left heart syndrome. So this is a surgical definition of a single ventricle repair, defining what is a single ventricle. And now you have the many anatomical ventricles variants like tricuspid atresia, unbalanced AV septal defect. You have double inlet ventricles, double outlet right ventricle with a large remote VSD, especially if it is a large inlet kind of a VSD or a muscular VSD. Classical is a hypoplastic left heart syndrome. Pulmonary atresia with intact ventricular septum where you don't have a good inflow, you don't have a good ventricle on one side. And there can be many other situations where you feel that you are not able to establish a two good ventricle repair. So these are some of the examples of anatomic variants of single ventricle. Now what are the physiologic variants? You have balanced parallel circulation. You have significantly reduced pulmonary blood flow, that is either inadequate blood flow or obstructed blood flow. So you have excessive cyanosis. Any kind of example, pulmonary atresia, intact ventricular septum, you have an inadequate blood inflow, you have an obstructed outflow. The second thing is you have excessive pulmonary blood flow. So you have a unobstructed or excessive blood flow. Typical example is you have a double inlet ventricle with unobstructed blood flow. You have a tricuspid atresia, classical 1C with excessive pulmonary blood flow. You have an obstructed systemic blood flow. That is typical example is a hypoplastic left heart syndrome. You have an obstructed systemic blood flow, or you have a ductus dependent systemic circulation. So you have any kind of a physiological variance which is associated with anatomical variants. So you have anything with tricuspid atresia, and here you have any kind of a valence parallel circulation, you have a tricuspid atresia transposition situation, or tricuspid atresia, severe stenosis or atresia. You have excessive pulmonary blood flow, you have single ventricle physiology with unobstructed pulmonary blood flow, the baby is presenting with severe pulmonary artery hypertension and ductus dependent systemic circulation. So the classical example is hypoplastic left heart syndrome. So these are the physiological variants associated with anatomical variants. So what is the general approach when we try to see a baby for a effective single ventricle repair? We have to maintain adequate systemic perfusion. We have to have adequate hemoglobin and oxygen saturation. These are the basic requirements for starting the baby for palliating single ventricle repair. Maintain normal ventricular function, so you have to prevent ventricular dilatation or hypertrophy. Establish systemic venous to pulmonary artery connection in multiple stages. Prevent and control the arrhythmias. So these are the general approach, and you have to start this approach as soon as you start the baby, maybe from neonatal life. Now, in which situation we try to intervene early? If you have a systemic outflow obstruction, the classical example is the hypoplastic left heart syndrome. We need to have an unobstructed outflow. You have a baby with severe cyanosis, pulmonary atresia. You have excessive pulmonary blood flow, you have ventricular dilatation, severe pulmonary artery hypertension. And you have, when we try to see many babies with heterotaxis syndromes, not only you have an abnormal, structurally abnormal heart, in addition you have an obstructive pulmonary venous return. So these are some of the indications. In a single ventricle situation, you don't need to wait for going them to even infancy. You may have to intervene in early neonatal life or in very early infancy. So examples that I was saying, you have a child with tricuspid atresia, pulmonary atresia, duct dependent pulmonary circulation, you have to intervene. You have a double inlet ventricle with a severe pulmonary artery hypertension, excessive pulmonary blood flow. You have to intervene, you have to prevent the pulmonary artery hypertension, you have to prevent the left ventricular dilatation. This child needs the early pulmonary artery band. You have a child with mitral atresia with intact interarterial septum. You can't allow the child to remain, because the child will sooner or longer will develop severe pulmonary venous hypertension. Child with hypoplastic left heart syndrome, obviously who has a duct dependent systemic blood flow. You have a child with pulmonary atresia with intact ventricular septum, you have a duct dependent pulmonary blood flow. So these are some of the examples in single ventricle situations. You cannot afford to wait for a longer time. You have to intervene as early as possible, sometimes on emergency basis in first or second day of life. So this is some of the example I'm just trying to show you. You see a child with tricuspid atresia and you see near intact interarterial septum. You have to intervene this child early. The same patient I'm trying to show you, almost intact interarterial septum, but one of the AV wall is neoarthritic. Now this is another example with a child with a mitral atresia, significantly hypoplastic left ventricle and near aortic atresia. The same child I'm showing in a different view. This is a classical example of a hypoplastic left heart syndrome. Mitral stenosis or near mitral atresia, aortic atresia and duct dependent pulmonary blood flow. So these are the kind of children babies you need to intervene very early. So what do you do in early surgical palliation in neonates and infants? You have to do a systemic to pulmonary artery shunt if you have a baby with a single ventricle with pulmonary atresia and duct dependent pulmonary circulation. Second thing is pulmonary artery banding in patients with excessive pulmonary blood flow, because you have to control the pulmonary artery pressure and pulmonary vascular resistance. In effect, it will reduce your late ventricular dilatation. Sometimes pulmonary artery banding is not the only procedure. You have to repair the systemic outflow obstruction. So that is classical of hypoplastic left heart syndrome. There we don't do pulmonary artery banding, we do a shunt with a aortic arch repair. The second thing is if you have an abnormal or anomalous obstructed pulmonary venous return, you have to do a pulmonary artery band with repair of the pulmonary veins. And in addition, if you have a child with a mitral atresia with excessive pulmonary blood flow, you definitely need to do a wide atrial septicectomy, because if you do not do the wide atrial septicectomy, the baby will develop pulmonary venous hypertension and effectively severe pulmonary artery hypertension and may not be a good candidate for a single ventricle repair in future. So this is again, I'm just showing you some example of a single ventricle with pulmonary atresia, duct-dependent pulmonary circulation, and which need a aortopulmonary shunt. This is a child with a double inlet ventricle, and if you carefully see, you have a bulboventricular foramen, and I'll just talk about that in future a little bit more. You see a pulmonary artery band in position, which is shown here, and you have a aorta which is coming out of the outflow chamber, and this is the pulmonary artery where the band is applied. I'll talk about this bulboventricular foramen in short. And this is a child who had one of the AV valve which is atretic, needed a wide atrial septicectomy in addition to pulmonary artery band. So these are some of the situations, and see, in this situation doing just a balloon atrial septostomy may not be a good answer, because balloon atrial septostomy, we know that we cannot create a very effective large intra-atrial communication. We have to really, especially in patients with mitral atresia, we have to relieve this pulmonary venous hypertension, and we need to have a wide atrial septicectomy in this kind of a situation rather than just doing a balloon atrial septostomy, because it will not decompress the left atrium effectively, and some amount of a pulmonary venous hypertension will definitely remain. Now, after doing this, these are all initial palliative procedures in patients with single ventricle who, when the babies come really very, very sick. Now, you have either done a BT shunt, we have done a pulmonary artery band, we have done some additional procedures like septicectomy, relieving the aortic arch obstructions. Now, these babies come for a second stage. So, either we do a balloon, this bidirectional Glenn shunt, or in some situations we may do hemifontan, or if we feel that we can wait for some more time, they can directly undergo completion fontan. Now, at what age we do, the centers have their different strategies, but by and large, bidirectional Glenn is to be done by the age of around 6 months. There are a couple of advantages, especially if you do a shunt in small babies. Really, how effective that palliation will remain over the period of time, we are always a little skeptical about it. If you do a Glenn shunt at 6 months of age, we know that there is a high incidence of sudden shunt blockage, especially if you do the shunts in neonatal life. We feel much safe, and it's a very secure kind of an anastomosis if you do a bidirectional Glenn. So by and large, it's done by the age of around 6 months. If you have an effective pulmonary band and you feel that the child is growing well, and if you can wait for 2 to 3 years, you can as well do a completion fontan at the age of 3 years. But by and large, the strategy is around do a Glenn by around 6 months. The other advantage is that if you do an early Glenn and take out the shunt, it reduces your left ventricular dilatation over the period of time. Again, that's one of the risk factors for a completion fontan at a later stage. Now, how we evaluate the children pre-bidirectional Glenn. I don't want to go into too much of a choices criteria. You know, there's 10 commandments what are really required for the need to assess very carefully. Now, most of these 10 commandments are become obsolete, but there are certain things which are must for effective single ventricle repair. And now, mostly I'll talk to you about how do we try to effectively evaluate them pre-operatively by echocardiography. And the most important parameter is your pulmonary artery anatomy. Especially if you have a prior BT shunt or a prior band, there is a high chance that your pulmonary arteries are distorted. And if you have any issue as far as anatomy is concerned, as I said, this is all physics. So you need to know your diameters of the pulmonary artery because effectively they decide the resistance in future. So try to look for pulmonary artery anatomy in detail. If you have any issue, try to get another imaging like CT, MR, angio, whatever your center is comfortable with. Then the second thing is assessment of pulmonary blood flow. Again, it's little difficult to just see on echocardiography, but if you have a band and then you can get a gradient across the band, eventually you can just try to see about how can be the pulmonary blood flow. Whether you have a presence of azygos, because you know during the glension usually they try to ligate the azygos. So you, especially if you have a try to see your IVC which drains into the right atrium, or you have a situation like IVC interruption with azygos continuation. You know, when you have IVC interruption and azygos continuation, the surgery which is done is called as a Kawashima repair, because most of your SVC flow and most of your blood flow from the lower extremities go into the Glenn circuit in this kind of a situation. See whether you have a single SVC or a bilateral SVC, because in that situation you have to they have to undergo bilateral bidirectional Glenn. See whether you have a heavy wall regurgitation, because again it will lead into further ventricular dilatation. And as far as the surgical strategy wise, whether in addition to doing a bidirectional glension, the child needs a heavy wall repair at the same time, so that also needs to be assessed. If you are dealing a child with a pulmonary atresia who has a shunt, we need to define about the aortopulmonary collaterals if you have any. And the most important thing, another, is the size of interventricular communication, as I was talking to you about the bulboventricular foramen. And if you are dealing with a child with a double inlet ventricle and your aorta coming from the outlet chamber, it is very, very important to assess the size of the interventricular communication or the size of the bulboventricular foramina, because that is effectively the outflow to the aorta. And it's very important in single ventricle situation, you don't or you should not have any subaortic obstruction. Your obstructive bulboventricular foramina will eventually act as a subaortic obstruction in future, and again that is a bad subset for a single ventricle repair. So as I said, you definitely need to see your branch pulmonary arteries in detail. If you feel they are a little hypoplastic, or you are not able to assess them properly, or you have any difficulty in imaging, just try to get other imaging modality to define the branch pulmonary arteries in detail. Now this I am just showing you, if you can appreciate, if you see any non-pulsatile flow going below the aorta from the subcostal view, I am just trying to put a color. This is a blue flow, and just see a venous blue flow going from the abdomen above. This is the IVC interruption with azygos continuation. So this is a very, very important information to give, and then you carefully see this azygos drains into the right SVC, because as I said, the surgeons need to do an operation called as a Kawashima repair in this kind of a situation. This is example of a bilateral SVC. You see a right SVC, left SVC. It's very important. It's important in all congenital heart diseases to define, because even the cannulation from the surgeon side depends upon when you tell them it's a single SVC or a bilateral SVC. But definitely it matters a lot in patients who undergo Glenn operations, because they need to do bilateral bidirectional Glens. See, these are the additional aortopulmonary collaterals, and in especially single ventricle situation, we will not like to have additional aortopulmonary collaterals. If you see them on echocardiography, definitely they will need a cardiac catheterization, angiography. You have to embolize these collaterals. Two things: they'll give excessive pulmonary blood flow. They'll eventually will increase the pulmonary artery pressures in this kind of a situations, and again they won't be a good candidates for a fontan in future. So carefully you need to see about the aortopulmonary collaterals, and if you have any doubt about especially if you have a child with a pulmonary atresia who have a prior shunt and you see some this kind of aortopulmonary collaterals, see to it that you effectively manage these collaterals before surgery, and all these patients definitely need cardiac catheterization, angiography to define the collaterals, and if you see their little bigger one, you have to coil embolize these collaterals prior to the surgical repair. So again, this is one of the example of I think a narrow pulmonary outflow tract. Yeah, so this is one of the very important thing which I need to discuss about. This is a child with a double inlet left ventricle, and if you carefully see, this is above one is the outlet chamber and down is a single ventricle. And if you effectively see, you carefully see, you have a significantly restricted obstruction at the bulboventricular foramen. You have a pulmonary artery which is coming from the single ventricle aorta, which is coming from the outlet chamber. And especially if you have a band into the pulmonary artery, there is a high chance there will be a significant hypertrophy at the coronal septum, and you have again more and more restriction to the bulboventricular foramen, and your aortic outflow is going to be restrictive. I think I'm forgetting this equation, but there is if you go into the Rebecca Schneider's book, you have a formula where you have to measure the bulboventricular foramen in two perpendicular views, and there is a formula when you say that whether the size of the bulboventricular foramen is effective or it's not effective. In that situation, there are a couple of strategies the surgeons need to have. One is they have to restrict the interventricular septum to make the bulboventricular foramen non-obstructive, or sometimes if you see this baby in a neonatal life, you have a significantly restrictive bulboventricular foramen, your aorta comes from the outlet chamber and the pulmonary artery comes from the main chamber. You have to adopt something, a strategy like a DKS, like you have to do a Demar's-Case standstill operation and do a shunt kind of a repair. So see to it that you do not have a restrictive bulboventricular foramen, because now what they say, if you just rule out your pulmonary artery distortion, you have adequate pulmonary artery pressure and vascular resistance, the single most risk factor for the long-term fontan is having a sub-aortic obstruction, because that will give rise to ventricular hypertrophy in future. Your LV-EDP is going to increase, and those are going to be not a suitable candidate or not a good candidate as far as the long-term outcomes for fontans are concerned. So see to it that you do not have this restrictive bulboventricular foramen. You go through the equation. I've forgotten that equation, but most of equal labs you have this formula of measuring the opening of the bulboventricular foramen in two perpendicular views, and see to it that you try to calculate according to the body surface area, and it's going to be effective big bulboventricular foramen. Sorry. Now additional surgical measures, and we need to look for them before we send the baby for patients for a single ventricle. That, as I said, if there is a azygos, we need to demonstrate that if possible, because during surgery the azygos need to be ligated. If there is a distortion of the pulmonary arteries definitely need to be plastic. If there is a significant AV wall regurgitation, usually in the neonatal life when they undergo the first palliation, either a shunt or a band, the surgeons don't prefer, or the centers don't prefer to touch the AV wall in the first period itself. But when you are doing a Glenn, you have a bigger kid, you are in a much more controlled situation. They are not very sick on ventilators and inotropes, and also the repair of this AV wall usually is done in the second stage. If you have any accessory pulmonary blood flow, especially the aortopulmonary collaterals, we need to eliminate them prior to surgery. And if you, as I said, if you have a systemic outflow obstruction, that definitely need to be addressed at this time. So these are some of the just a picturesque position. Now we have done a Glenn shunt. we usually periodically follow them, because you know that after doing a Glenn, there is a possibility as the children grow and they increase their activity, the weight gain is more, they are going to be desaturating over the period of time. Even if they say in this situation, another very important point is your resting oxygen saturation may not have any meaning. Most of the time after a bidirectional Glenn shunt, we expect a saturations between 80 to 85%, because you have only the SVC blood flow going to the pulmonary circulation. And as the children grow, definitely they start dropping those saturations, that they have significant effort intolerance. And if you try to measure the saturations in the echo lab, many times it's like 85%. And if you carefully ask the child or the parents, the child is not taking active participation in the sports, he gets easily fatigued and tired, and that's because they're dropping the saturations as they grow and they become more active. The easiest way that if you put them on the treadmill, the more and more the IVC blood flow starts going into the systemic circulation, you see that the saturations drop to 60s. So that's the way you try to many times assess the efficacy, or try to see what is the time you try to complete the Fontan in them. So this is the way clinically we try to assess them. The another way is not only you see the saturations clinically, you try to see the hemoglobin and PCV, because that is more indicative of your oxygen saturation rather than just measuring or oxygen content rather than just measuring the oxygen saturation by pulse oximetry. So if you try to, that is a clinical evaluation of patients with Glenn, and you try to do a echocardiography, SVCs directly anastomosed to RPA. So we try to image them in the suprasternal short axis view, where you see the SVC anastomosis to the right pulmonary artery. Always use a low velocity scale, because these are the venous flows, and you use a low wall filter setting. Pulse Doppler shows biphasic low velocity forward flow. I'll just show you that. And if you see anything that is there any disturbance of flow across the Glenn shunt, you need to see whether pulmonary arteries are normal in size or there is any pulmonary artery distortion. Another very important thing, we always say that the Glenn is flowing well, but try to see the whole innominate in the suprasternal view, whether you are seeing a decompressing vein. In that situation, the saturations are going to be really, really low, because you are happy your Glenn is flowing well, but what is all happening, because your Glenn pressures are on the higher side, your innominate starts decompressing into the IVC. So try to look for the decompressing vein. Actually, and in fact, just on clinical evaluation, I think many times you might have seen, if you have a little higher PA pressures prior to Glenn, the child come next time and you open the shirt and all, and you see all the decompressing vein even on the chest wall. So on echocardiography also, try to see the decompressing veins from the suprasternal view. They come from the innominate vein. And another most important thing which are not able to evaluate just on echocardiography is pulmonary AV malformation. So you see a child who is just saturating 40% and 50% after Glenn. When you see their brain is functioning well, your heart is fine, there is no lung issue, but the child is saturating very, very, very low, and the cause is pulmonary AV malformations. You know that after Glenn operation, they are very prone for pulmonary AVMs, because the IVC blood doesn't reach the pulmonary circulation at all, and it is because of the loss of hepatic factor which is going to the lungs, which is responsible for this pulmonary AV malformations. And if you see multiple pulmonary AV malformations after doing a Glenn, and you should not get into a practice of closing these big pulmonary malformations, because it's not going to help in future. If you close one, the other one is going to open. So the only treatment for pulmonary AV malformations post bidirectional Glenn is completion Fontan. The moment you connect the IVC into the pulmonary artery, your hepatic factor is going to go into the lungs, and your pulmonary AVMs will automatically subside. So this is just an interesting 3D picture to show you the functioning bidirectional Glenn. So this is our regular suprasternal view. We show the SVC, which is connected to the right pulmonary artery, and you are always expected to see a very non-pulsatile smooth flow from the SVC into the pulmonary artery. See, this is one of the example where your pulmonary arteries are distorted. You see a significant turbulence at the SVC and pulmonary artery side. Your right pulmonary artery is small, especially if you have these patients who have a prior VT shunt. Your PS get distorted, and you many times see this kind of a turbulence if the pulmonary arterioplasty is not done at the time of a Glenn shunt. See, these are the typical patients. You know, the SVC pressures are quite high. They come immediately after the Glenn. If you see them, they come with a bloated faces. You give them diuretic for some time, it may resolve, but usually the problem is here. And if the SVC pressure is really very high, you again start seeing decompressing veins from the innominate. So try to look for that, and these are the patients you need to really aggressively address them as far as the pulmonary artery morphology is concerned. If possible, you can dilate them. If they are little bigger kids, you have to stent them, or you have to send them for early surgery. They need to really do a pulmonary arterioplasty and completion fontan. You should not see this after the Glenn shunt. So after the Glenn is done, usually the third stage or a completion fontan. This is a different policies at different centers, but most of the centers I say feel that they do a completion fontan by 5 to 8 years of age, depending upon the center's expertise, experience, and their role policies. Because as we know, we do a Glenn shunt between 6 months to 1 year of age. Over the period of time, definitely where the child will get more and more blue and symptomatic, and by and large we do a completion fontan by 5 to 8 years of age. And there are two ways: either we do a lateral tunnel fontan with interarterial communication, or a extracardiac conduit. And now most of the centers practice to have an extracardiac conduit from right IVC to pulmonary artery. There is, if you go through the Western literature, there are a lot of reports where they try to complete the fontan even by 2 years or 3 years. Sometimes we may have a problem of the size of the conduit for that particular SVC, and even the length of the conduit, because the child is going to grow over the period of time. So our centers usually prefer to complete the fontan between 5 to 8 years of age. Again, doing it too late have issues regarding pulmonary formation of pulmonary AVMs and the children becoming more blue. If you have a mild aortic wall regurgitation, then the LV dilatation and increasing the LV and diastolic pressure may be a problem. So again, as far as the preoperative fontan evaluation is concerned, is the same thing about the anomalies of systemic pulmonary venous return. They are more common with asthenia, polysthenia, and see to it that whether we are not dealing with severe systemic AV wall regurgitation. The another point from size of the pulmonary arteries definitely is the morphology of the ventricle is one of the important criteria for success of a long-term fontan in future. You know that we have a single ventricle of RV morphology and LV morphology, and we always break our heads to define how is the ventricular morphology, and in many situations it may not be possible. But you know why it's important that if you have a single ventricle with a LV morphology, the most important or commonest subset is the tricuspid atresia, which have a good long-term outcomes after fontan, mainly because your morphology is of left ventricle morphology. So on echocardiography, if you can make up that, it's a good input given to the surgeons prior to the surgical repair. As I was talking to you about the size of the interventricular communication, see to it that you do not have a restrictive bulboventricular foramen, size of the pulmonary arteries, and ventricular function. So these are the most important echocardiographic parameters we always like to have. And as I made the ventricular assessment of ventricular function, I guess it may be a single most parameters which decides about long-term fontan, because ventricular volume overloading, especially if you have a prior large aortopulmonary shunt or you have a significant AV wall regurgitation, You have a ventricular dilatation, which increases wall stress and myocardial hypertrophy. It has inappropriate changes in mass and volume ratio of the ventricles. Ventricular hypertrophy, remember, it's a major determinant of pulmonary blood flow, because if you have a ventricular hypertrophy, you have increased left ventricular end-diastolic pressure that reflects into increased LA pressure and pulmonary venous hypertension, which eventually leads into pulmonary arterial hypertension. So if you can measure, or if you have some kind of a parameters to measure the preoperative mass volume ratio, I realized the limitation, because most of our parameters and our guidelines or the criteria for a mass or mass volume ratio are for two ventricles. We try to look for transposition with regress ventricles and all. There are no strict guidelines for a really measurement of a mass or mass volume ratio in the single ventricle situations. So there may be limitations for assessment of this, but you try to assess the LV function as much as you can, and I think over the period of time, MR may be a better, give you a better answer for answering this kind of a situations. And what are the risk factors to try to assess on echocardiography is, as I said, the most important pulmonary artery distortion. pH may not be really assessed by echo again. C for significant AV wall regurgitation, ventricular function, ventricular hypertrophy, complex systemic and pulmonary venous return. This is not now a very significant risk factor, because most of the systemic and pulmonary venous abnormalities in the systemic pulmonary venous return can be effectively managed surgically. But if you see long-term results of single ventricle with pulmonary venous abnormalities, that the long-term results or if you see the this Fontan completions over the period of time, the patients with a single ventricle with abnormal pulmonary venous returns have one of the worst outcomes. So not that we can't repair and they are not a candidate for a Fontan completion, but the long-term results of a single ventricle with abnormal pulmonary venous returns are definitely not very optimum. And try to see for systemic outflow obstruction. This is a completion Fontan with a cardiac conduit. Now, if you see do a child Fontan completion, and the child comes to you for a follow-up, because you know when you complete a Fontan, they are lifelong your patients, and you definitely need to evaluate them periodically for their long-term outcomes. We are expected to face a lot of problems with after completion Fontans. So definitely you need to evaluate them periodically. And the most important challenge we find is difficult windows. We can't just see them, because especially if they are like now in their early teens, you don't have any windows. Hardly, very difficult to see the conduit, and a smooth flow from the conduit still can be managed to see from parasternal, apical or subcostal windows. If in a difficult situation, try to see from transesophageal echoes, and you have to really use the very low filter, because they are very low velocity flows. So this is one of the Fontan from the subcostal long axis view, and then this is a conduit which is been seen. Many times we are able to see the conduit in a short axis or an end-on kind of a view from apical four-chamber view, and this is if at all you want to see the fenestration here, and you see a small fenestration. And as you know, one of the reasons for why the baby or the children get blue after Fontan completion is if you have a significant size fenestration. So if you have a child with significant cyanosis after Fontan completion, look for a backfill leak, large shunt through fenestration. Sometimes you might have missed a communication between the left SCC and the left atrium, and you know that there are some studies or there are some subsets of patients you can have pulmonary AV malformations even after completion Fontan. See for persistent effusions they can have, and I don't want to go into other details complication, but somebody comes for a follow-up of Fontan, see for pulmonary artery narrowing, systemic outflow obstruction, whether the child is developing progressive subaortic stenosis, pulmonary venous or systemic venous baffle obstruction, AV wall regurgitation, and poor ventricular function. These are some of the abnormal pulmonary artery flow patterns in patients with Fontan. And now I'm just showing you one of the the patient who has undergone Fontan completion and see this ventricular function. And especially if they have AV wall regurgitation over the period of time, any systemic outflow obstruction, you know that this Fontan is not going to do well over the period of time. Now, if you have a child with a univentricular heart with pulmonary atresia, non-confluent hypoplastic branch PA, severe AV wall regurgitation, dilated ventricle with poor function, severe pulmonary hypertension present at first time at a later age, usually they are unsuitable candidates in the initial evaluation on echocardiography itself. Most of the patients, usually we try to catheterize them. I don't want to go into detail of that. Usually pre-gland is everybody's choice if you have anatomical details, branch PAs, collaterals, and they are adequately seen on echocardiography. You don't have issue regarding the pulmonary artery pressures or LVDP, you can directly go for a Glenn in some situations, but most of the centers may still prefer to do a cardiac catheterization to see for pulmonary artery pressures and check for a LV and diastolic pressures and see there are no collaterals. Even your CT MRI can give you good answers except direct measurement of pulmonary artery pressures and LV and diastolic pressures. Usually there is a consensus that pre-Fontan definitely a cardiac catheterization is required, and most of the centers are doing cardiac cath. We need to do a study for anatomical details, for PA anatomy, Glenn anastomosis, decompressing veins, pulmonary AVMs, pulmonary artery pressures, LV and diastolic, and pulmonary vascular resistance, and to measure the LV and diastolic pressure. And most of the centers are very comfortable knowing the numbers, and therefore most of the patients definitely will need cardiac catheterization. I understand MRI is definitely replacing in certain situations for the anatomical details. The pulmonary artery pressure and pulmonary vascular resistance remains an issue, and still I feel cardiac catheterization may be required. Thank you very much.